Supply College, Bangalore. I am presenting a case on ecological management of cervical disc prolapse in a beagle dog. A 4-year-old male beagle dog presented with a history of head down and lot of pain in the neck and lot of tremors on the neck muscles. Since 2 days, it was very dull, not able to move also properly. And upon physical examination also, it revealed lot of pain in the neck. We were unable to fix the neck, means the face up or head up, and laterally also. And when we pressing the head down, is showing lot of pain. And physiological parameters like blood test and hematology and biochemistry are normal. Initially, because of lot of pain, initially started with the, as usual, the painkiller and some nerve tonics, and further advice for the cage rest. But even after 1 day, if not shown much improvement, is worsening, then it is further referred for further diagnostic test. Like as usual for the radiography and next subsequently the MRI. In radiography of the cervical region, except the calcification of the C4 and C5 vertebra, the other vertebrae looks the margin and anatomy were normal. And the same animal was subjected for photosonography. Calcification of the vertebra. The MRI shows at the level of a calcification and protrusion of the disc at C3 and C4 causing mild to moderate disc compression. You can see the images. And also my early stages of myelomalacia. Coming to the treatment part, in such cases we have to go for surgical support, that is cervical disc decompression. Selected a ventral sort procedure under a general anesthesia, pre-medication, PMD analgesia and pre-anesthetic and anesthetic. The animal position on the dorsal recumbency with extended neck as shown in the picture. The skin incision was made from the mid of the mandible to the up to the Z point. Mandibular. After the skin incision, the muscles were separated, the cervical muscles. Then there are trachea, esophagus, and the carotid artery were pushed to right and expose the longus muscles. The longus muscles, it attachment to the ventral bone was separated slowly, and the bone was exposed along with the disc. Our interest of the disc was selected, that is C3 and C4. The bone was drilled, the ventral vertebral bone was drilled with the help of a ronger, make a slot, and after that with the dental burr we made a slot starting from the ventral tubercle, that is tubercle, to the preceding and succeeding vertebra in between. Okay. The ventral tubercle, the caudal aspect of the C3 and the cranial aspect of the C4 in between this, as shown in the picture. And with the burr, the disc, the bone was slowly drilled, and with the help of flushing and aspiration, we remove the small pieces of the bone once you enter into the canal, slowly whatever the disc is prolapsed into the canal was slowly removed with the help of branches and also with the help of the curated. This is how it looks, the bone and the remote, the prolapse disc material. And after the removal, after the conformation, the muscles which are separated were closed back onto the surgical wound with a routine pattern. The animal is stabilized with a neck bandage for some time. Every 3 days we removed and rebandaged till the wound heals, and we advise the initial 1 week for a complete cage rest, and slowly we ask the owner to leave the animal for little free movement, and ask the owner to monitor for any seizures and other things. Post-operatively, as usual, for any surgical procedure, what generally we use the broad spectrum antibiotics and anti-inflammatory and some enzymes are used for the proper recovery. And wound is healed without any complication, and 10 days we remove the stitches. This is a post-operative videos. You are able to dip the head now. Coming to the discussion part, cervical disease are more common in at the age of 3 to 6 years, and C2 and C3 discs are most commonly affected. Major clinical signs are nose down, that is head down, and arched back with lot of neck pain. Do not exceed 1/3 of the width of the length of the vertebra bodies. That means to say, preceding succeeding vertebra what you select, don't go beyond 1/3 of the vertebra. And complications generally we will see a transient neurological worsening after the surgery and venous sinus hemorrhages. That's why when you are making a groove in the vertebra, don't go on the lateral side, go to the lateral side. Exactly at the midline, you do it, and if you go on the lateral side, the sinus, venous sinus will be there. Lot of hemorrhage you notice. To prevent that, always use the arsenal based soap bandages and blood for some time. MRI is the best choice for diagnosis, and the dogs which are more mobile, in the sense they are moving active, their recovery will be faster. Thank you.
Any questions on this article?
It is suddenly it happened. It may be its age of 4 years. Suddenly it's happened. It was a mild one. It's a mild one. That's why in the MRI they told they're very mild. Even in such cases, when the neck will be extended and given some supportive bandages, it will relieve little pain. But we consider for surgery and we.
So grade 1 that kind of short technique can be used.
Yeah, because in further it has to worsen. Still some more it will go on. Push up the fine.
Was there any post-operative MRI taken? Post-operative MRI. And say one more observation. I think as per you say immobilization was done for 10 days. But I think that may not be sufficient. But what you are seeing in human cases, minimum 4 to 6 weeks. And what type of bandage was used for the neck?
Just a supportive bandage, sir.
Are there any neck collars available on par with the human beings for this animal?
Yes, sir. Same neck bandage is used.
Neck
But
collars,
yes,
collars.
But in this animal, the instability was not too much. Because the vertebrae we are not use more than 50%. It's 30%, 30%. That gives more support.
Okay. And I think you have one more paper. No? That is surgical management of distal condylar fracture in a Model-owned dog.
The first one, please.
Can you please shift over for the next presentation? Recognize my third in the row.
Yeah, this is the second presentation. It's on surgical management of distal metaphyseal and condylar fracture of a humerus of the Model-owned dog. A 1-year-old female Model-owned dog was presented with a history of fallen from second floor and limping of the left forelimb. And when it is presented, it was a non-hearing illness. Swelling was there on the distal humeral region, left humeral region. Pain, crepitus, all cardinal signs of fracture was there. Even when palpated, I felt the fracture. Neurological thing were normal. The case was taken, radiograph was taken of that part, and the radiograph revealed the distal condylar fracture, where even in the radiograph we are not unable to see both the condyles looks aligned, but when you open the surgical side, both the condyles, the intercondylar fracture also it happened. That is almost a Y-shaped fracture. Coming treatment. Generally, the condylar fractures are treated in many ways. They use the trospany and plating is nowadays is practiced, and single plate, double plate, many things they use. But we have the opportunity to use one DCS plate. We are using for the other surgical procedures. But here, normally the DCS plates are available in the 90-degree. The barrel and the plate will be in the 90-degree. We, for our work, modulated into many formats. Here, one little modification of DCS plates were done as per the shape of the bone or the running of the shaft. It's a 3.5 mm screw and 3 mm. As usual, the anesthetic protocol, pre-medication with ceftriaxone monoxidil as a preemptive anesthesia, and anesthetic xylazine is used, pre-anesthetics, and anesthesia is used a combination of ketamine and propofol with maintained with the animal position and the lateral recumbency in the affected limb and down, exposing the medial side of the fracture. And skin insertion was done on the distal end of the humerus, exposing the subcutaneous tissue and the muscles. The muscles were dissected slowly. We preserved the main nerves, ulnar nerve, musculocutaneous nerve, and median nerve, along with the brachial artery and brachial plexus vein. Upon dissection, the trapezius and the bicep brachii muscles are pushed caudally to expose the sharp fracture site and expose the distal condyle of the medial condyle with the epicondyle. The drill was made with the drill bit size of 7 mm to fix the barrel of the plate. Once it is fixed, the barrel sitting in the one of the conduit, use the one more drill bit, 3 mm drill bit, to make a drill in the other conduit via the barrel, and the screw was fixed with the cortical screw was used, size of 3.5 mm screw. As shown in the picture, and the remaining the upper shot is fixed with the 3 mm screws. This is how it looks after the correction. Proper alignment, all the fracture fragments are in place. Post-operatively, the broad spectrum antibiotics, amoxicillin tablet is used, and analgesics, methamphetamine and tramadol combination was used, and enzymes and calcium support, fever, and restrict the animal activity for some time, not for a long days, 3-4 days, and later animal started moving slowly with a leash walking, and later on treatment. And sutures were removed on the 10th post-operative day. After 3 weeks, after 2 months, the distal fractures are more common in the humerus, and highly comminuted fractures and multiple fragments are seen. And before fracture treatment, regardless of the approach, the important thing is that we should save the nerves and the vasculatures present at the distal part. And additional, here the barrel in the modified DCS plate provides extra stability to the intercondylar fracture of the whole implant. Thank you.
Any questions? Thank you, Dr. Mahesh. The next paper, what's the name? Next I call upon Dr. Muslim for presentation of 2 papers. The first paper is evaluation of intramuscular volatile
Second.
on sedation, induction, recovery qualities and vital variables in cats.
Assalamu alaikum and good afternoon everybody. This is Dr. Muslim, a PhD scholar from the Division of Veterinary Surgery and Radiology, Faculty of Veterinary Science and Animal Husbandry, Skuast-K. I'll be presenting a brief description or a brief presentation on the topic evaluation of intramuscular zoological anatomy on sedation, induction, recovery qualities and vital variables in cats. So the presentation is very brief and it's divided into introduction, a brief description about zoological, followed by aim and results. We all are very well acquainted with the fact that anesthesia is required for efficient and painless surgical procedures. Whether brief or comparatively simple or prolonged or complicated surgeries, it's always necessary that the patients be anesthetized so that the procedure, surgical interventions can be carried out efficiently and painlessly. So, although the anesthesia is primarily used for patient's own benefit, but it's simultaneously necessary for the safety of veterinarian as well. And the nature or the choice of anesthesia depends upon the nature and duration of procedure and the origin of potential pain. We have used volatile 100 in the study, which is a veterinary anesthetic for dogs, cats, wild animals, and zoo animals. It's an injectable anesthetic and sedative which is used for minor surgical operations and short duration surgeries. It's indicated for restraint and minimal surgical procedures for short duration, and it's a ready-to-use combination of two components in a fixed ratio. One of the components is thalidomide hydrochloride, and the other component is zolpidem hydrochloride, which is a non-phenothiazine diazepam, and thalidomide being an aryl amino cycloalkyl dissociative anesthetic. It provides rapid onset and dose-dependent depth and duration of action. So the aim of the study was is to evaluate the effects of volatile on sedation, induction, and recovery, and various vital variables in cats. 12 cats that underwent castration and opiate were included in the study, and Zolotil was used at the dose rate of 5 mg per kg intravascularly. Regarding the results, as I said, 12 clinically healthy client-owned cats were used in the study, and all the animals were grouped, or all the animals were administered Zolotil at the dose rate of 5 mg per kg. The onset of anesthetic varied from 2.5 minutes to 10 minutes in all the cases, while the total anesthetic time that varied from 120 to 140 minutes. Regarding the 8 cats, it was found that in 8 cats we found that smooth induction with mild salivation. However, 5 cats showed rough induction and hyperexcitation and mild excitation. And in case of recovery, there was 8 cats that showed rough recovery and 4 cats that exhibited smooth recovery. Regarding in the beginning of the study, we administered atropine subcutaneously before administration of Zolotil, as we know that Zolotil, we know the fact that Zolotil enhances the salivation. So we administered subcutaneously atropine, but in only few cases, because what we observed that the saliva that thickened, and that thickened as the procedure went on, and during recovery it hampered the breathing of the animal. So it was stopped for the following cases. Regarding physiological parameters, heart rate, respiratory rate, and blood pressure were measured at the time of administration of the drug itself, and followed by 15 minutes until the completion of the surgical procedure, which was up to 30 minutes, and all the physiological parameters were gained in the normal range. So Zolotil, being a safe anesthetic which can be used for surgical interventions, obviously which are short duration, and obviously the dosage can be managed to overcome the rough recovery. Either it can be added to other anesthetics available, or we can lower down the dose, or likewise. Thank you very much.
I have a question. Because you used atropine randomly, few cats you administered atropine and some other cats for various reasons. And as you know, the atropine is a parasympathetic or it's a vagolytic drug, and it will enhance the heart rate. But when you take the average, is it okay? Because few cats are gone with atropine, where the atropine would have induced the tachycardia, and some other cats where atropine was not given, I don't know what has happened to the heart rate.
Yes, sir. That was also one of the reasons we stopped the use of atropine in the following cases. And all these cases, they were maintained on, for OAs, sorry, the cats that underwent OAs, they were maintained on 2% acetylcholine, and propofol we used for induction. That also was one of the reasons, because that atropine also enhances the heart rate in conjunction with the sorbitol itself.
This is part of your master degree work?
No, sir. Not my master degree.
Independent.
It was in addition to that. Yes, sir.
Any other questions? Okay, you can move on to the next paper. Gastrointestinal linear foreign bodies in cats, a study of 7 cases.
Yes, sir. Next presentation, please. So another presentation is on gastrointestinal linear foreign bodies in cats. It's a study of 7 cases. These 7 cases were also presented to our clinical complex, and they underwent. Gastrointestinal foreign bodies, they are common in small animals, cats and dogs especially. Depending on the location and severity and duration of the obstruction, the animal may present with various clinical manifestations, ranging from anorexia, ranging from retching, anorexia, etc. And linear foreign obstructions are more common in cats in comparison to dogs, because of their playful behavior. What was the aim of the what we aimed? We aim to determine the radiographic localization of the obstruction, which aided in the diagnosis of linear foreign body in cats, and to investigate the operative treatment options. The study material comprised of 7 cats, which were presented to our clinic, and the cats belonged to different breeds, ages, and genders, with a history of retching, acute or chronic vomition, and anorexia. Treatment plan, treatment plan was decided depending on the localization of the foreign body, severity and duration of the pathology. Treatment was planned after the identification of foreign body causing the obstruction, and all foreign bodies were removed with surgical intervention. The common foreign material retrieved were threads with needle and shoelace, and there was also a part of a piece of sponge that was also retrieved. In addition to that, a piece of broomstick which was stuck in the mouth. It was stuck in the oral cavity of one of the cats. That was also retrieved. Localization and identification of foreign bodies, we utilize radiographic imaging. For radiopaque foreign bodies, they were quite visible on the radiographs, and for laces or threads, we could witness the changes in the small intestine, and followed by ultrasonographic examination. As you can see in the picture on the right bottom, it was a sharp needle which was stuck from 24 hours in the small intestine of the cat, and the cat was witnessing retching continuously. And in other pictures, they were shoelace. There was a shoelace in the right top picture. There was a shoelace which was stuck inside the intestine, and there was a thread, only thread. As in one of the cases, the owners what they had done, they had cut the part of thread which was stuck in the mouth. We opted for surgical removal of the foreign body, and it was simple laparoscopic procedures, and taken all the precautions into consideration. This was one of the cases. The animal actually did not cooperate for the examination of oral cavity at first. But by the time of the surgery, when we anesthetized the cat, we managed to check the oral cavity, and the thread was encircled around the tongue, which obviously the plication was quite visible on ultrasonography. So we were sure about the foreign body obstruction, linear foreign body obstruction. This is what we extracted from the small intestine of the cat after we performed the intestine and we performed the surgery. The other, this was a piece of sponge that cat had ate without owners knowing, obviously. So, and in one of the cases we were able to extract the shoelaces. And this is the case where the cat was playing with a broom and accidentally had ingested a piece of broomstick which was stuck in the mouth. And when owners came, obviously the cat did not cooperate for the examination of the mouth. When the owners came, they were worried, and there were plenty of people with the cat. And when we anesthetized the cat, I managed to examine the oral cavity and where I witnessed the stuck broomstick. And just with the anesthesia, we did not operate. Just with the anesthesia, I was able to remove the stick with the help of a scalpel. For the surgeries we performed, post-operative care was 2 cats unfortunately died in the post-operative period. And as I said, in one of the cases, the owners had pulled the thread, tried to pull the thread out, which had resulted in perforation in the intestine. Multiple, in that case, there were multiple perforations in the intestine. So that was one of the cases that we lost in the post-operative care. And obviously, the duration of pathology varied. Some owners did not even know what was wrong. So, infection due to bacterial translocation and intestinal perforations caused by linear foreign body are inevitable in delayed cases. So, hence, prompt and immediate diagnosis in linear foreign body affects the prognosis very well. In conclusion, it's extremely important to carry out a detailed examination of the oral cavity in cats, showing symptoms of pathology of gastrointestinal origin. And it is not advised to pull the linear foreign bodies which are entwined around the tongue or protruding out from the anus to reduce the risk of intestinal perforation. Thank you.
Any questions?
In all cases, was the definitive diagnosis was made before the procedure, or it was done, obstruction was detected after investigating to laparotomy?
No, it was diagnosis was made before the surgical intervention. Only after we arrived at the diagnosis, we convinced the owners of the surgery. It was before the surgical procedure to diagnose the conditions. Yes.
Ma'am, as you says, there are linear foreign bodies. So most of the cat owners, they are reluctant to do operatives. So how can you convince them to do the surgeries? Because in our clinics, most cat owners do not perform surgeries. So how can you convince to perform the same procedure?
Convincing part is difficult. It's how we interact with the owner. Apart from that, see, when these all cases I have been part of all these cases. So in all the cases, what we did, there was no option. And there was no option. Mostly what happens, the cat resists the oral examination. So we are not able to delineate it right there. What we do, there are only 2 options. We can't, as I said, we can't pull it up. We can't do anything physically. We have to use our anything. If they want I would say if owners want to save the patient's life, they have to opt for the surgery. There is no other option. Given all the considerations.
Actually, there is only solution to the problem that was the surgery. And we could not have done anything else. So for that, we have to have the issue, or else we have to make that which matters. That's all. So it is the choice of the owner and what they want. Thank you. Now, actually, we are running short of time, so I would request Balachandra sir to do the honors to our chairman, co-chairman, and rapporteur on the dais. I requested Balachandra sir to come on the dais. The session will be ended and for 10 minutes break for tea. Thereafter, we'll be starting the thesis session. That will be separately announced thereafter. Ranganath sir, please come on the dais.
अरे बोलते चाय पी लेते
I will request Debaki sir to come on to dais. I will request Secretary to come on to the stage.
I request Bharatiya, please. We have another parallel session for posters. So we want to felicitate the chairman, co-chairman and rapporteur of the poster session. So first, I request Dr. M. Chandrasekhar, Professor, Veterinary Medicine, chairman for the poster session. Please, sir. The co-chair for the session was Professor H.S. Brady. Please, sir. Brady, sir, please. The rapporteur for the session was Dr. B. Mahan.
Wait a minute, sir. Sir, wait a minute. Wait a minute, sir. Look here, sir. Smile, please.
Dr. Mahanan, please come to the stage. Thank you, sir. Thank you very much.
क्या है
Now I request that we will be going for a cup of tea. It will be hardly a break of 10 minutes. Thereafter we will be starting the session of the MSc Thesis Award. And for that matter, it is my humble request that we will be within 10 minutes we will be back over because the judge for the session has to leave at earliest. So it is request that we will be back by that time. Please.